Welcome, everyone, and thank you for joining our webinar today on health disparities and health equity during the COVID-19 pandemic, fact versus fiction. We are extremely fortunate today to have an author whose fingers are on the pulse of health disparities and equity issues, who will be presenting to us today on this important topic. Let me introduce you. Dr. Patty Rose is president and founder of Rose Consulting in Miami, Florida. She earned her master's degree in Health Service Administration from Yale University School of Public Health, followed by her doctorate in health education from Columbia University Teachers College. She's the president and founder of Rose Consulting, through which she offers speaking engagements, workshops, and consultation in the U.S. and abroad. She's also author of 2 books for Jones and Bartlett Learning. Those titles include Health Equity, Diversity, and Inclusion, which just came out in a 2nd edition last month, and Cultural Competency for the Health Professions. And with that, I'd like to turn the presentation over to Patty. Patty?
Thank you so much, Suzanne, for that introduction. And it is truly my pleasure and my honor to have this opportunity to talk about this very important issue in the midst of a pandemic, the COVID-19 crises. So I'm going to begin today with a definition, because I think it's important for us to make sure that we're understanding the terms. So the first definition is health disparity. Health disparity is essentially a difference or gap in health status between varying racial or ethnic groups based on a number of factors. So we want to keep in mind here that I'm only giving factor examples, not all of the factors. So some of those examples are socioeconomic and educational status, race, culture, ethnicity, and other population characteristics. Racially, one group is not inherently healthier than another. There are factors that contribute to health disparities that I just mentioned. So we know that it's not an inherent scenario. Social injustice and systemic problems in the United States healthcare system, and note that I have system with quotes, contribute to health disparities. The second definition that I want to go over is health equity. There are many definitions of this term, so I chose for our discussion here a definition by the Robert Wood Johnson Foundation, which is as follows. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So as this pandemic scenario is occurring globally, and particularly for our discussion here in the United States, we can see that many of these obstacles are surfacing. They're not new obstacles. They're obstacles that have been there, but they are coming to the forefront in the midst of this pandemic. I'm going to begin with a fact. Dr. Jerome Adams is the Surgeon General of the United States. He is an African American man, and he stated the following. He said that Black Americans are more likely to have pre-existing conditions and lack access to healthcare, and that he has high blood pressure, asthma, heart disease, and is pre-diabetic. He stated, so I represent that legacy of growing up poor and Black in America. The legacy that he refers to is based on the reality of a key social determinant, socioeconomic status. Black people are not more susceptible to contracting the coronavirus that leads to the disease COVID-19, but there are often existing comorbidities due to inherent weakness in the U.S. healthcare system that may lead to poorer outcomes and higher mortality rates from the disease. So I really want to take a moment with this because it's very important to understand once again that what the Surgeon General is saying here, and what I am saying, quite frankly, is that it is not that Black people or Black and Brown people in the United States are inherently sicker. It is because of factors in our society that lead individuals to be sicker in terms of lack of access to care and all of those factors that I talked about before. And we want to make sure that we understand that, because if we don't, we can get a thought process or create a paradigm that leads one to believe that a person is sicker simply because he or she is a Black or brown person, and that is definitely not the case. Comorbidities. Let's begin with fiction. Some may falsely argue that genetically there are illnesses that tend to exist in the Black population, as an example, that contribute to overall lower health status. Fact. If this myopic view stands in a scenario such as the current pandemic, this may transpose into the perspective that Black people are more susceptible to the disease. The argument of genetics has no substantial basis as a valid and sole explanation for health disparities. Comorbidities exist due to lower socioeconomic status and the lack of overall care afforded to poor people in Black and brown communities. So this may sound repetitious as I'm saying it again and again, but this must be understood in order for society to help those individuals who are suffering to a greater degree from this disease, COVID-19, and the comorbidities that we're actually discussing in this case. Key factors that contribute to higher mortality rates among emerging majorities during the COVID-19 pandemic and beyond. So sometimes I use the term Black and brown people, and sometimes I use the term emerging majorities, because these Black and brown people that we are referring to are actually moving toward becoming the majority population in the United States. So I don't use the term minority in my book, um, uh, nor do I use it when I'm speaking about these issues. So let's begin. Food injustice. This is one of the factors. Educational disparities, health literacy concerns, the digital divide, mass incarceration, poverty, racism and discrimination, lack of access to care in community-based providers of color, and lack of quality housing. So in my new book, Health, Equity, Diversity, and Inclusion, I discuss each and every one of these factors in depth. Sometimes it is my writing directly, and sometimes it is a contributing author who has expertise in a particular area. So when we look at food injustice as an example, because I won't go through all of these, but in the lower socioeconomic communities, you find that people may not have the basic food that they need to eat healthy. And consequently, they are not able to maintain a healthy diet. There may not be a large supermarket in the neighborhood where they can access fresh fruits and vegetables. Or there may be a large supermarket in the community, which is very rare because there's usually very small stores that are in the communities. But if there is, the prices in the store might be too high for the community members to afford. So we refer to this as a food mirage. So that would be a problem as well. Because if you're not able to access healthy foods and you're eating primarily processed foods to fit your budget because those foods are cheaper, then you're not having an optimal diet. And I also want to use one other example from this slide, and that would be the digital divide, because most of the information that is being provided around COVID-19, we can hear on the news and in all different scenarios that, oh, just go to the internet or just go to your favorite cable television news program and watch and get information there. This is a problem if you don't have access in your home to these various scenarios, including broadband, including a computer itself. Perhaps your smartphone is very, very limited in terms of what you have access to. And so until we resolve the issue of the digital divide for lower socioeconomic communities, then we cannot expect that individuals are going to go to these sources to get the information. We have to get back to the prior way that things were done, and that's going out into communities and communicating with people and providing leaflets and information and pamphlets and all of those kind of things. And this would have to be worked out within the context of COVID-19 because we have social distancing. So this is so complicated that we cannot just assume that, oh, this is hitting one community more than another without giving a full explanation of some of the problems that are taking place. So the importance of demographic data in the midst of COVID-19, that becomes critical. One of the most critical steps that can be taken during this crisis is to ask important questions. When data leans in a particular direction, demographically, particularly in terms of higher mortality rates among specific groups, namely Black and Brown people, there needs to be a determination as to why this is happening, particularly in this pandemic. Demographic data must not be limited to age, which is very important, by the way, but it has to go beyond that. That has been the case in the initial analysis of COVID-19, where demographic data was limited. But it must be expanded to consider race, ethnicity, gender, income, education, and etc. So we already see this in effect because as soon as the demographic data began to be released in this society, we immediately began to see that Black people and Brown people were being affected to a greater degree than any other group in the nation. And this comes as a surprise to many, but it is not a surprise because it is the reality all of the time in the United States of America in terms of health disparities. It is through this type of thorough analysis that trends are determined, leading to better possibilities to develop solutions for those segments of society that are most severely impacted, along with the rest of the individuals who are experiencing the health problem. You know, the fact that I'm sharing this is very surprising to me, particularly from a public health vantage point, because as a student at Yale, in the Yale School of Public Health, and as a student at Columbia University Teachers College, where I studied community health education, one of the primary things that we learn is the importance of demographic data and stratification of that data. So the fact that it took us so long to get to the demographic data was absolutely shocking to me. And I feel that it should be very clear to us all for this particular pandemic and going forward that the demographic data tells a story that cannot be gathered in any other fashion, because those numbers are so telling when we look at the deaths that are occurring in various communities of color in this country. We realize health disparities are real. And I think that is an eye opener for some, but for many, it's something that we've known all along. So let's look at health inequities explained. In an article, Georgia C. Benjamin, executive director of the American Public Health Association, stated the following: I think the biggest challenge is the fact that people of color, African Americans, start out with health outcomes that are disproportionately poor when compared to white Americans. The highest risk, if you get this disease, is to someone 60 or older with chronic disease. With African Americans, you start with a population that is disproportionately sicker. And if it gets exposed, it will have a higher death rate. The reasons for the health inequities include access to health care, continues Benjamin. He goes on to say, and differences in the quality of care African Americans receive. A lot of what makes you healthy happens outside the doctor's office. So, all the social determinants, including racism and discrimination, housing, access to transportation, and education, are a factor. And I'll say differences in individual behaviors that we all have based on our life experiences. So, clearly, he has explained this just straightforwardly without any questions whatsoever as to what is happening. This is well documented. We don't have to speculate. It's the reality of what is happening today, and we're all witnessing it on a very large and vivid scale. So I'm going to use Chicago as an example now. In the book, my book, Health Equity, Diversity, and Inclusion, there is a clear statement that is relevant to the current data related to COVID-19. Whitman et al. Reviewed the research and conducted on health disparities in Chicago and concluded the following. This chapter on Chicago was written by Dr. Anthony Monroe, so I want to make sure that I point that out. So he provided this information. Recent analysis of health conditions in Chicago have revealed that Blacks fare worse than whites or Hispanics on a variety of indicators, including stroke, diabetes, and breast cancer mortality, as well as maternal smoking. These analyses have also shown a strong negative and statistically significant correlation between these conditions and median household income at the community level, at the city level for breast cancer. There is extensive support in the literature for the relationship between socioeconomic status and poor health. So Dr. Monroe included this quote from Whitman, which explains, actually Whitman et al., which explains a very important fact to us. But I want to add a little caveat here. The caveat that must be added is that Hispanic, according to the Office of Management and Budget of the United States, which establishes the categories on race and ethnicity, notes that Hispanic is an ethnic, not a racial group. In terms of lower socioeconomic status, Black and Hispanics experience similar health outcomes as Black non-Hispanic people in the United States. So Hispanic people in general are part of the health disparity scenario. There's no doubt there. But we have to take into consideration that if you are a Black Hispanic, your situation might even be worse than if you are a non-Black Hispanic person. So I did want to mention that as a point of clarification. So continuing with Chicago as our example regarding COVID-19, Chicago sheds light on something that is very important. And that is, while Black residents make up about 29% of Chicago's population, a whopping 72% of the city's residents who have died from COVID-19 so far are Black. So 72% is the latest percentage that I have seen. And I believe that this is incredibly alarming. And it is based on the information that I have been providing in the prior slides. Many of the individuals impacted have lower incomes and are essential workers. We keep hearing this term in the media, essential workers, essential workers. And I think that that is so important because essential means that these are workers that are needed in our society. Health disparities, according to Natalie Moore per NPR, she stated the following in terms of health disparities. Health disparities and access to care play a key role. Many essential workers holding down jobs like driving buses, childcare, or in grocery stores are Black. As the pandemic continues to take a toll on health and economics, there are calls for addressing underlying racial inequities. So clearly, in Natalie Moore's example, when she said buses, childcare, grocery stores, those are just examples. When we begin to look at essential workers, we have to really look at the entire spectrum and understand that a lot of those positions are the lowest paid positions in our society. They are positions where people may be hourly workers, where people may be living paycheck to paycheck. There's so much going on within the context of the word essential workers that we just don't want to limit it to these two words that everyone is repeating without really digging into them and understanding the plight of the people who are working these jobs. We must value and appreciate them, but at the same time, we have to understand how they are being impacted so that we can help. So this is a national problem. Although I used Chicago as an example, I want us to all look at this particular graph that is presented here from the Brookings Institute. If you look at Michigan, Illinois, North Carolina, and South Carolina, you can see a clear disparity in terms of the percentage of COVID-19 positive diagnoses and the percentage of the state population. This is a great problem as we look at this on a national basis. And I think what has to be done is that we have to go state by state by state, and we have to look at demographic data in every state, in every pocket, in every community. We can do this while the pandemic is happening, and we can also do it after the pandemic is over so that we can get a better understanding. But whatever we do, we have to move quickly because in this case, people are dying on a daily basis at numbers that are much greater than what we see in our normal daily scenario, even though that in itself, when we look at health disparities and health inequity, when there is no pandemic, it's very serious. But now the problem is even greater. So I want to end today with solutions. My book is entitled Health Equity, Diversity, and Inclusion, Context, Controversies, and Solutions. Because in every case when we deal with health disparities, we know how to lay out the problems. We identify the data, we put it all out there, and we discuss it and discuss it and discuss it. But we must move towards solutions, especially in this crisis and beyond. There should be no pretending that it is not understood why Black and Brown people, emerging majorities, are suffering to a greater degree than others in the midst of this pandemic, with higher mortality rates. It is a known and established fact that the reasons are health disparities caused by lack of health equity, racism, discrimination, social injustice, including food injustice, environmental injustice, poverty, and beyond. All of these issues are laid out in great detail in my book in the second edition. The first edition was Health Disparities, and I talked exclusively about that. But the second edition is moving us toward health equity. It's a forward thinking book because it's time for us to think in a forward fashion regarding resolving health disparities. Until these realities are faced and discussed head on and solutions are implemented in the normal course of life and in every health crisis, Black and Brown people in the United States will suffer more than their white counterparts. COVID-19 has brought these realities to the forefront. So the time is now to actively move towards developing and implementing solutions. Thank you all for listening to me. I'm going to turn this back over now to Suzanne.
I'd like to thank you for watching the webinar today, and I want to thank Dr. Patty Rose for a very eye-opening and insightful presentation. On the screen, you'll see Dr. Rose's latest book, which she referenced today during the presentation. If you have any questions or comments regarding the webinar or the text you'd like to share, please email me, Suzanne Walker, at swalker@jblearning.com. On behalf of Dr. Rose and myself, we hope you stay healthy and safe. This ends today's webinar. Thank you.